Intracytoplasmic sperm injection, ICSI. Indications, procedures, and outcomes. Introduction to intracytoplasmic sperm injection, ICSI. Intracytoplasmic sperm injection, ICSI, is an advanced assisted reproductive technology, ART, used in vitro fertilization, IVF. It involves the direct injection of a single sperm into an egg to facilitate fertilization, making it a valuable option for male factor infertility and other complex fertility cases. Key topics covered: indications for ICSI, step-by-step procedure, success rates and outcomes, potential risks and limitations. Indications for ICSI: 1. Male factor, infertility. ICSI is the preferred method in cases of severe oligospermia, low sperm count, asthenospermia, poor sperm motility, teratozoospermia, abnormal sperm morphology, azoospermia, absence of sperm in ejaculate requiring sperm retrieval, sperm retrieved surgically, e.g. TESE, PESA, MESA. 2. Fertilization failure in conventional IVF. ICSI is recommended when previous IVF cycles had low or failed fertilization rates. Unexplained fertilization failure despite normal sperm parameters. 3. Use of cryopreserved sperm or oocytes. ICSI improves fertilization rates in sperm frozen for fertility preservation, e.g. before chemotherapy. Oocyte freezing cycles, where thawed eggs may have a hardened zona pellucida for pre-implantation genetic testing, PGT cases. ICSI reduces sperm contamination when performing genetic testing on embryos. 5 cases of immunological infertility. When anti-sperm antibodies prevent sperm penetration into the egg. 6. ICSI in non-male factor infertility. Some clinics use ICSI routinely in advanced maternal age, limited egg numbers, embryo biopsy cases, PGT. ICSI procedure step by step. 1. Ovarian stimulation and egg retrieval. Controlled ovarian stimulation using gonadotropins. Transvaginal ultrasound guided egg retrieval, 34 to 36 hours post-trigger injection. Eggs are assessed for maturity, MII stage, required for ICSI. 2. Sperm collection and preparation. Types of sperm collection methods. Fresh ejaculated sperm, processed via density gradient centrifugation. Frozen thawed sperm requires specialized preparation. Surgical sperm retrieval used in cases of azoospermia, TESE, PESA, MESA. Sperm selection for ICSI. Motile sperm with normal morphology are chosen. High magnification techniques, IMS. I may be used to select the best sperm. 3. Microinjection, ICSI procedure. ICSI is performed using a high-powered microscope and micromanipulators. Immobilization of the selected sperm using a micropipette. A thin glass needle pierces the egg's zona pellucida. The sperm is directly injected into the cytoplasm. The micropipette is carefully removed, leaving the sperm inside. Eggs are incubated and monitored for fertilization, 2 pronucleus stage. 4 fertilization check and embryo culture. 16 to 18 hours. Post-ICSI, successful fertilization is confirmed by the presence of 2 pronuclei, 2 PN. Abnormal fertilization, e.g. 1 PN, 3 PN, is discarded. Embryo development. Timeline, day. Stage, day 1. Fertilization check, 2 PN. Day 2 to 3, cleavage stage, 4 to 8 cells. Day 4, morula stage. Day 5 to 6, blastocyst stage. Blastocyst culture improves selection for embryo transfer. 5 embryo transfer and cryopreservation. Best quality embryos are transferred on day 3 or day 5. Remaining viable embryos can be frozen for future use. Fit. Success rates and outcomes of ICSI. 1 ICSI. Fertilization and pregnancy rates. Fertilization rate: 70 to 85% of injected eggs fertilized normally. Clinical pregnancy rate: 40 to 50% per cycle. Varies by age and embryo quality. Live birth rate: 30 to 40% per cycle. Factors affecting ICSI: success, egg quality, maternal age, ovarian reserve, sperm quality, DNA fragmentation, morphology, embryo quality, and endometrial receptivity. Higher success rates with blastocyst culture and transfer. Frozen embryo transfer, FET, in optimized endometrial conditions. Pre-implantation genetic testing, PGT, for embryo selection. 2. ICSI versus conventional IVF success rates. Factor: ICSI, conventional IVF. Fertilization rate: 70 to 85%, 50 to 70%. Pregnancy rate: 40 to 50%, 35 to 45%. Live birth rate: 30 to 40%, 25 to 35%. Best for male factor infertility: yes. No. ICSI is superior for male factor infertility, but shows similar pregnancy rates to IVF in non-male factor cases. Risk and limitations of ICSI. 1. Risks to embryo and pregnancy. Egg damage: approximately 5% of eggs may not survive injection. Higher risk of genetic abnormalities, e.g. Y chromosome microdeletions inherited from father. Increased risk of birth defects, slightly higher than conventional IVF, approximately 1 to 2% increased risk. Genetic screening recommended for severe male factor infertility, Y chromosome deletions, couples with known genetic disorders. 2. Ethical and clinical considerations. Overuse of ICSI in non-male factor infertility. Routine. ICSI in all IVF cases increases costs without clear benefits. Clinics should evaluate patient-specific needs. Careful patient selection for ICSI. ICSI is most beneficial in cases of male infertility, low fertilization rates, and PGT cycles. Conclusion: optimizing ICSI outcomes. ICSI is a revolutionary technique in art significantly improving fertilization rates for male factor infertility and other complex fertility cases. Its success depends on egg quality, sperm health, and embryo culture conditions. While ICSI offers higher fertilization rates than conventional IVF, it should be used selectively to balance risks and costs. Pre-implantation genetic testing, PGT, and optimized endometrial preparation can further enhance pregnancy outcomes. With continued advancements in micromanipulation technology, ICSI remains a cornerstone of modern fertility treatment, offering hope to couples with severe infertility challenges.